waveform is the most important thing that you need to learn about classic APRV, the flow waveform. So if you decided to forget everything about this, don't forget this one, because that's how you're gonna kill patients, right? So where are you gonna practice? Just a geographical area when you're done.
New England.
North Carolina.
Big city.
Like where? Come on.
Somewhere on the East Coast.
North or east or south?
North.
North, okay. So both of you are gonna be, when you walk into your first job, you are gonna be considered idiots until proven otherwise. You are gonna be considered genius until proven otherwise. The Northeast is always like this. Idiots until another doctor, another one of them. They're stumbling over each other. Down there, it's usually the opposite. I tested it myself. It's amazing. So if you're in the Northeast, especially if you're in the Northeast, and you say true APRV, classic APRV, and you put the patient on, the patient has pneumothorax, nobody's gonna listen to you anymore. It's gonna be a stamped idiot, like forever, right? So you pay attention, please, to this one. So the flow is basically no flow. No flow, nothing. You saw my chest, like nothing is going, right? Except maybe the little breathing on your own here, blah, 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 blah. But the major flow happens when the release breath happens. We call that the release breath. It goes like this, like this, like this. That's the major flow. It's all in the negative, mostly in the negative, right? So what do we call this in other modes of ventilation when the exhalation looks like this? We call it auto peep. The exhalation is not complete. That's auto peep. So if we call it auto peep here and the respiratory therapist measure it, he will have a heart attack because the auto peep here is huge. 45, 50, huge auto peep, right? So this mode, that's another claim to fame to this mode, is that it debunked the belief that the auto peep is inherently bad. You can actually use the auto peep to your advantage, which this mode is doing, is depending on using the auto peep to its advantage, but regulating it. So as if you're like playing with fire in the circus, either people are gonna clap for you or you burn yourself, you know, so that's exactly the analogy here, right? So, so how do you regulate the auto peep? They measure the ratio. There's a ratio that has to be measured here. We put the cursor here and see what the maximum negative flow, and that's called the peak expiratory flow. And then put the cursor here and call it the end expiratory flow. And if you divide EEF by PEF, it should be 25 to 75%, which is a good number, good, nice range, wide range that you can easily achieve. So that's that. So how about if you did the ratio, you measured the ratio, and the ratio came out to be 85%. What is happening, and what would you do for the patient? So basically, if it's 85%, that means if you look at this curve, where does the 85% exist? Like this is 100, this is 50, so this is 50%. Where is the 85%? It's going to be around here, right? So basically, you terminated the breath here early, basically. That means if it's 85%, that means you're having more auto peep. And this lung is going to have a barotrauma, decreased venous return, all of the stuff that happened with bad auto peep. And what you need to do is prolong the time. Just prolong the low time. And this will go all the way to 50%, okay? Now, how about if it's 10%? 10% meaning that you allow this curve to reach all the way to here. And if it reaches all the way to here, that means that, huh? You have to decrease the time, but what does it mean? What is it going to do to the patient if it's 10%?
You're just sitting there having expired for too long. Or
yeah, you exhale too long. That means what? That means let's exactly, it's going to collapse, it's going to de-recruit, it's going to have hypoxia, and then have atelectrauma the next breath by opening the collapsed alveoli multiple times. Let me tell you, if this thing reach all the way to zero flow, it's the hurricane theory, right? The hurricane is or the hurricane, analogy. You have the high pressure, area and I have the low pressure area, and then it just flows, keeps on flowing until the two pressures equalize. So if you allow this to go all the way to zero, that there is no flow anymore, the hurricane stopped, that means you allowed the lung to see the low pressure. Now the lung has seen the low pressure. Now the lung experienced 0 as a low pressure, or 5 as a low pressure, which is extremely low for somebody with ARDS. That will collapse everything. That's horrible. So in essence, the lung never sees the low pressure in this mode. We don't allow it to see the low pressure because we don't allow this to reach all the way to the baseline. And that's the whole essence of like using the auto PEEP to your advantage. Now, when you have somebody on regular vents, at least in this hospital, regular vents, the respiratory therapist evaluate the vent every 4 hours and PRN. APRV every 2 hours when it's APRV. And during that evaluation, they have to do this measurement of the ratio. If it deviates from around 50% or so, they tell you and you see what you want to do. So let's say, but I also encourage you and the nurses to do the same. It's so easy. It doesn't change the settings. You're not changing the settings. So nobody's gonna slap you on the hand and say, well, don't change the vent. Freeze, move the cursor, get these two numbers and measure them. And alert the respiratory therapist, say, listen, you haven't seen this for some time and this is whatever. So let's say you measure the auto PEEP, you measure the ratio in the morning and your rounds in the morning and it's 50%. And then you measure it again at night and it's 60%. Both of them are acceptable. But what is happening to the patient? Is the patient improving or worsening?
That would mean that the end expiratory flow is more than the peak expiratory flow, so their resistance is increasing probably.
So it could be that there's more obstruction, like resistance to the flow, or it could be that they recruited. So let me just show you. So this is it, right? This is 50% of this. This is 50, and this is 100, for example, right? Now at night, you come in and it's 60%. 99.9% of the time, it's that this went here. So now that's the new wave. And this is 60, so it becomes 60%, right? The more this goes like this, the more it goes like this, that's severe ARDS. It deflates very quickly. The more it goes like this, that's more COPD, right? I'm just giving you another analogy. There's more COPD. COPD has two characteristics: obstruction and very low compliance. Very low compliance, right? So 99% of the time, it is actually due to improved compliance of the patient, which is low. Did I say low compliance?
Yeah.
High compliance. The COPD has high compliance. Like lungs are easy to inflate, right? So what I'm saying here is that majority of the time, that's what happened in the APRV, is that they recruit more and they become more compliant. How do you know that this wave is improvement? Huh? Because of this. This area here is the area under another additional area under the curve, which means that the tidal volume had improved with the same settings. I didn't change the settings at all. Same time, same pressure, same everything. And it was 50% and now 60%. So if this is a new waveform, that means that there's an additional area under the curve, and that means that that the patient improved, right? Recruited, and that happens 99% of the time, and almost guaranteed. I almost guarantee you that this will happen. This mode has so much pressure in it that will guarantee you. This is another claim to fame to this mode. It will recruit. It is guaranteed that recruitment for the patient, except the rare circumstances. Okay. Now, in the remaining 1.1% of the time, this one is going to look like this. This, like you were saying, more resistance to exhalation. This went here. So the wave became like this. Again, looks like a COPD waveform, but this is a lost tidal volume. So the tidal volume had decreased and that means worsening. There's more obstruction that's happening. The reason I'm saying this doesn't happen except in 0.1% of the time, because what does the pulmonologist do when it comes to asthmatic patient? As a resistant asthmatic patient in the ER, that is, we tried everything, all medications, all intervention, intubated, blah, blah. What do we do? Last thing that you do for asthmatic patient to improve their bronchospasm is to increase the PEEP, right? By increasing the PEEP, you keep this bronchi a little bit, you know, keep them from constricting. And it's true, you know, you keep more PEEP inside. You know, the bronchi want to constrict chemically inside, the troponin and the tropomyosin and all, trying to pull, but it can't, because, you know, there's some more pressure inside, so it can't constrict. So that's with what, increasing the PEEP from what, from 5 to 8, 5 to 10. Here I'm talking 35 of pressure, right? 35 of pressure for 6 seconds. Show me what bronchus will be able to constrict. No bronchus will be able to constrict here. No. Even if they, like, you give him calcium and you know, give him you know, induce asthma and acetylcholine, inject you know, newstigmine, give him acetylcholine, they will not constrict. They won't be able to. It's just the pressure. They can't overcome this pressure inside. So that's another claim to fame to this mode, that you will never ever hear wheezing in APRV. You're not going to be able to hear it. But the 0.1% of the obstruction that we say it's obstruction, it happens because of upper airway. You know, the mucus plug or the tube is kinked or something like that. If that happened, that's what you're going to see, and you're probably going to recognize it right away. Or if you're still using the HME filters, the filters sometimes many times it clogs and give you this pitch. All right? So so that's that. So that is it. That is it, madam.